Hello, everyone, and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today or in the future. We recognise and value the knowledge and wisdom of people with a lived experience of addiction, their families and supporters. We celebrate their strengths and resilience in facing the challenges associated with their recovery and value their important role in the development and delivery of health and community services. My name is Rebecca and I will be facilitating today's webinar, Ways to Get Community to Reflect on Their Drinking or Drug Use. This webinar is a part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. This webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We like our webinars to be as interactive as possible, so please do ask questions via the Q&A function. The questions will be collated and answered by our presenter at the end. Please be aware that our webinars are recorded and are later made available on the Turning Point website. We encourage you to stay to the end of the webinar and complete the exit survey when the QR code appears on a slide at the end or via email later today. Our presenter will share a PDF copy of the files following the presentation. Now, finally, I'd like to introduce our presenter, Professor Kylie Lee. Kylie is a professor in public health and leads the Priority Populations Research Stream at the Centre for Alcohol Policy Research at La Trobe University. She holds honorary appointments with the University of Sydney, National Drug Research Institute and Burnet Institute. Her highly original research in alcohol and other drug use is led by community or health service requests. Thank you, Kylie, so much for joining us today.
Thanks, Rebecca. Hi, everyone, and thank you to the Turning Point guys and Shalini for asking me to speak today. I also want to acknowledge that we all meet on Aboriginal and Torres Strait Islander land. I'm also joining you all from the land of the Wurundjeri people of the Kulin Nation, and I just wanted to pay my respects to elders past, present and emerging. Can I also acknowledge the lands where you're all joining us from around Victoria or maybe Australia, and any Aboriginal people here with us today. This land always was and will be Aboriginal land. Just a note, today I'm going to be sharing a few photos, including some of colleagues from other parts of Australia who have passed away. Wanted to let you know I'm using these photos with the permission from families. Okay, I'm going to try my hardest not to cough through the talk. I'm originally from Darwin and I've lived in remote Top End. I did my music undergrad here on Wurundjeri land at the Con at Melbourne Uni. I worked from Sydney for Sydney Uni for many years, and I've taught Aboriginal drug and alcohol workers in grad dip and master's clinical courses at Sydney Uni. Now I'm doing this work from Wurundjeri land with my priority populations team at the Centre for Alcohol Policy Research. And I want to try and tell you today a bit of a story on ways that we found to get communities reflecting on their drinking or drug use. It's a little bit like speed dating. I'm going to try and show you 6 different resources and research my team has developed in the last 2 decades, and my challenge is getting through all 6. I wanted to start with this beautiful artwork from Terry and Sophia from Tijikala community in the NT, because it really helps ground me and remind me that no matter what tools are used to help people reflect on their substance use, it needs to be aligned with where each person and their family is at in terms of their stages of change in relation to their alcohol or other drug use. One way we've used to get communities to reflect on their drinking is by making it easier for communities to understand drinking and local patterns of substance use. What I've seen is when there is so much use in community, you might have a good picture of what's happening in your house and then the house next door and the house at the back, but it's really hard to step outside to see the whole community and to know where to start to address things, because it all feels very messy and really tricky for everyone. So one thing we did is we gathered a team of local researchers, and this example is from up in Eastern Arnhem Land in the NT where I said I'm from, to help communities step back and see what was happening across the whole community in relation to their yandi and their other substance use, and to feed this information back to everyone. But when we looked at, I promise this is the only graph of this kind that I'm going to be showing today, but when we looked at different ways epidemiological data is presented, so what I mean by that is how many people drink and how often they drink, etc., there was a great chasm, a really big gap in how to get this type of story understood broadly across communities. The local researchers I worked with really wanted everyone to understand their local data. 14-year-old young person thinking about starting Yandi through to a white-haired grandparent. But not many people were comfortable with maths, and the numbering system only went up to 10 in the local language. But there was a really great desire to understand their own data, so we had to find our own way. So we spent ages working out with a local artist and health workers and came up with these guys, and they represent the life stages of our study participants. We then turned it into an hour-style population pyramid where the lighter figures of people who currently smoke Yandi, or they call it Amarda in their community, and the darker figures are people that feel like their spirit is strong, and they were the people that weren't smoking Yandi. So you can see in the men, the Wanangorapa over here, that there were 9 out of 10 people smoking every day, really high rates. And it really, for these communities, created a flashpoint moment where beyond worries that people might have had about police trouble or trouble with dealers, a broad group of people were suddenly invested in learning more about how to help their community with worries from Yandi and other substance use. And this phrase, "Wa Ningarumba Arba Aganada," is what the local chair of the Land Council said to me. Oh, now I understand what's happening. Because I'm getting the whole picture from the community about how Yandi is affecting us and other substance use. At this time, after we fed back the communities their alcohol and other drug use data, Muriel, who was the then local Aboriginal mental health worker, she led the research with me, and she also had a clinical role in the clinics, said that she started to see more people coming to the clinics to get help. She also felt like more people were stopping her at the shops or after hours to chat privately about getting help or advice around Yandi. And this was a really big shift when before people were really worried about police trouble and trouble with dealers as well. The data really inspired Muriel and her community to find a way to help whole communities to reflect on their substance use. And for them, they decided to create movies. So we talked about lots of different ways that people can get health promotion messages out there. They wanted movies shot by a professional filmmaker, not by me. I did the early ones. I got retired quite early. The local Aboriginal mental health worker, so Muriel, she was the executive producer. What that meant in our context is that she had the power to stop filming at any stage. Many other people have written about this edutainment, so education, entertainment approach all over the world, looking at lots of health issues from diabetes to HIV. Muriel would often say, we need to be really smart in how we get the messages to community. We don't just want to give them boring instructional videos that play in the clinics or in the Land Council office and no one really wants to watch. She'd say to me, we're storytellers. Let's tell stories, but let's try and weave in the evidence-based messages. For us, the evidence was not just Western clinical evidence, but also local culture, and to really help her people reflect on their substance use. But for me, as the lowly producer, this meant making Muriel and the filmmakers' reality come true. She wanted it to be really realistic. So they wanted a plane to shoot a scene in. We got them a small light aeroplane. They wanted to shoot in a prison. We shot in a prison. So that the film could be understood as really as real life. She felt like that's what it needed to convey messages which were so tricky to talk about in community. I'm going to show you just a 1-minute teaser of the film, and then I'm going to quickly talk about it. So let's hope, Beck, that the audio works.
Can't tell me what to do. Like that.
Are you there? Can I just grab
So you saw the plane and you saw the prison. The actors in there were also either local community members or, in the case of the uniformed police officers, they're actually police officers who Muriel and the Aboriginal people who casted the film were happy to play the police officers. And then we obviously got permission from NT Police as well for them to play it and to be wearing their uniform, etc. in there. There are so many ways to get communities to reflect on their substance use, but there are no quick fixes, and limited funding and workforce shortages are ongoing issues. What we did is we took a community development approach to research. We took everyone along for the research ride. We worked out together how to feedback the findings, and then we started to come up with some local solutions based on what the local data showed, such as the film that I've just shown you. And what we found was that this really helped put the power back in the hands of communities to use their own data to inform their local prevention and their treatment efforts. Another way to get communities to reflect on their drinking is by making it easier to collect local data using digital tools. And this is really important because you saw before the picture of me and the local researchers on the jetty took an enormous amount of resources, and I had to go away and analyse a lot of that data. So we're looking at other ways that we can do it, which gives communities the power to collect their own data themselves and to analyse it themselves as well. Some of you might have heard me and Scott Wilson, an adjunct professor and CEO of the Aboriginal Drug and Alcohol Council, talk about the Grog app before. We developed it from 2015 to 2021 as a part of an NHMRC project grant. It was designed as a population survey tool, as we know that existing national surveys of Aboriginal and Torres Strait Islander people's drinking underestimates drinking among this group by up to 700%. And Scott and our team wanted to find a better way to work out how much people drink. And then we realised that we had this tool that communities could then use as well. But in order to do so, it really had to suit Aboriginal Torres Strait Islander peoples, whether you're in Wurundjeri land or Larrakia land in Darwin or Mabuntua in Alice Springs. We really wanted a comfortable space to tell a drinking story where people weren't going to feel judged, and it had to work offline, etc. So let's take a quick spin. So you can see here the first page of the Grog app. There are a whole lot of demographics questions that go beforehand. Two interesting things here is that Talia, who got these screen grabs for me, one of our team, has said that she's a woman, which is why I'm going to see pictures of women throughout. But I can change the audio as well to listen to English. I can listen to Pitjara, and the way that the app is developed is that you could even add in an Arabic track or a Mandarin track or any other track as well. Excuse me. Often find that when people are asking these, answering the survey questions, it's really hard for people to understand the timeframes, and you guys must have this in the clinical service as well. So we have anchor points to help people understand the timeframe that we're interested in. So when Talia got this screen grab, it would have been around September or October, because the app will work offline without the internet, and it will dynamically alter the timeframe to know that it's around, since the last 12 months is the footy grind finals. If I was to do the app today, it would send me out to around NAIDOC, because we're kind of in June and NAIDOC's around July. So to give me that 12-month time period. But if I was to say no, because we know many people might not identify as being a drinker, in quotation marks, etc. And there's lots of stigma and worry that, very justifiable worry that is associated with that. If you say no to the first question of have you drunk anything in the last 12 months, you then get this check question. And I can click through and say yes and then receive the questions, or I can say no and I'll just scoot out to much further in the end. Rob Hassan, who's a wonderful Aboriginal drug and alcohol worker, I'll explain some of his work later, always says to me, by this stage, we know that someone drinks something because I said yes and I said yes. But we're not just going to straight away ask, what did you drink? Tell me everything. We're going to have some soft landings. Not only is it going to help the person ease into the conversation, but it's also going to help jog their memory. So where was I and how many people I was with? I can pull this slider across and more people will come into my drinking circle. And then it lands me here, which is our main grog shop. In other, we have things like methylated spirits, but we also have things like cocktails. Aboriginal drug and alcohol workers wanted that in there as well, but we can move it around to other spots as well. Really important for us was to have a variety of containers because we know that people drink out of a range of containers which are not always just represented in the alcohol.gov.au standard drinks chart. So you can see here the water bottle. I can fill up my water bottle. I can also add fizzy drink or juice. And then I can pull it across and say how many I drank as well. It's obviously a different example with a sports bottle. But we know some people find it easier to drink to describe their drinking, in terms of what the whole group drinks. So if you enter a type of alcohol beverage, in my case, it was a type of white wine that is more than 7 standard drinks, it will then bring up this group or individual drinking. So this screen is not going to come up if I just put that I had a single can of beer. It's not going to come up. And then I can describe my drinking by pulling it over to say, yeah, I was a bit more gritty that day, or I can pull it right back to say, yep, out of all the group drank, I just had one of these bottles. So you can see here, Talia's saying I was a bit more gritty on that day. Our clinician friends on the team also said that in addition to asking about people's drinking, it's also really important to ask about periods of no drinking or dry patches, and that this is really useful for them to inform things like risk of withdrawal. So again, we do that in the last 12-month time period, and it's really fascinating. In a representative community sample study we did in South Australia, in the urban site, people were having up to 90 days of dry patch or 60 days of dry patch in the remote site. So these are consecutive days where people are not having anything to drink at all. So you can see here the same kind of slider. And as I mentioned before, we're asking about 12 months. So this slider will take you up to about 11 months and 3 weeks, and I can drag it across. Each person then receives a tailored feedback or some kind of brief intervention. And for us, it's based on the World Health Organization's FLAG model. So feedback, listen, advice, goals, and strategies. So as you can imagine, we don't have wonderful clinicians like yourself there. So we really wanted the app to be able to listen and also provide feedback to each person, but based on the answers that they gave in the survey. And quite a few community-controlled health services that we work with around the country are actually using the app as a health promotion tool because they don't always have people on the floor who can give a brief intervention that is really nifty and tailored. So this way the person can do the app and then receive a brief intervention. So on this screen, the app has automatically calculated where each person is at or where I'm at, and it's saying based on the WHO risk triangle. So based on my answers or Talia's answers that she entered into the app. And as I mentioned before, it does this offline, so which is really important so it can work when the internet is unreliable. So obviously you just need the internet to get the app onto the device to start with. Another example of a listen screen where the app calculates based on the person's responses that they might be dependent. So if I didn't meet the dependence criteria and we use ICD-11, I wouldn't receive this screen. The app brief intervention also gives a range of advice as well as harm reduction tips as well for people worried about their drinking, or maybe you can also go through the brief intervention as someone that doesn't currently drink. but you can still find out tips for others, for someone else, for someone who does drink a lot, to remind themselves to ask about thiamine, ask their pharmacist or doctor about thiamine. For me, it's really important to provide tools to help clinicians to feel comfortable to conduct a BI or a brief intervention, because we know from our Grog app studies of, as I mentioned before, the representative community samples, that if people drink, they're doing so way above the guidelines. But at the same time, we found very low prevalence of alcohol dependence. So 1 in 45 people, similar to the general population in Australia. So many people are not dependent, and they're usually drinking episodically in a heavy way, which is why tools like the brief intervention on the Grog app are so important for me to get that information and that feedback straight away out to people. But with Redfern AMS, we developed the alcohol awareness kit, and it's available for free online. Just ping me and I can give the address. We need to update it because I'd really like to add in there to help clinicians explain how relapse prevention medicines for alcohol work. And the brief intervention in the Grog app is based on this brief intervention too. So it's based on the alcohol awareness. Third resource, Rob Hassan, who I mentioned before, and is Aboriginal and Torres Strait Islander drug and alcohol worker. I think one of the most skilled people I've ever seen in delivering brief interventions. He always tells me that when he goes in to see a client, he's talking about planting a seed to get someone to reflect on their drinking in a way that suits them where they are right now, so they don't feel judged. And as I mentioned before, there is varying comfort in clinicians that I've met along the way doing this brief intervention dance. So last year we worked with some Aboriginal AOD workers to create 3 films and a talk to camera piece, and they're called Brief Yarns on Alcohol films. The work was funded by the tail end of a project grant we had to work with community controlled health services around the country, and it was about improving screening for alcohol for risky drinking, as well as treatment options as well in an Aboriginal primary care setting. I'm not going to show you the whole film. I mentioned to Rebecca at the start because it's 5 minutes long. But if you Google Brief Yarns on Alcohol, you'll bring up a free Vimeo link so you can view all 4 of the films in there. But in this yarn, the screen grab I've got, the client is Wayne, played by amazing Aboriginal drug and alcohol worker Jimmy Perry. The health worker on the right-hand side here, you see is Rob Hassan playing the health worker. Rob's obviously an Aboriginal drug and alcohol worker, as I mentioned. Both are Aboriginal and both are AOD workers. Wayne comes to the clinic with a sore leg and is not thinking about his drinking at all. Like, that's not on his radar at all, but he's just coming in because he's hurt himself and he wants to get back to work and to playing footy. And Rob helps gently plant the seed to get Wayne to reflect on his drinking, and in the end makes a follow-up time for that to happen. So there's other films as well about how to talk to someone who's dependent about their drinking and get them to think and seek help. And there's another one about how to talk with someone who's pregnant, who's drinking, and how to have that conversation. Obviously, these are only 3 different vignettes, and we're looking at writing a whole lot of other vignettes to make some more this year or next year. Okay, this last example is about elements to deliver bicultural alcohol care. And it was led by Gemma Purcell Kora. Gemma's a Gundungurra woman, so her country is near the or parts of the Blue Mountains. And it was developed as part of a project grant that worked with 22 community-controlled health services, again, like the funding of the films. So the work really arose from a systematic review that Gemma led in her PhD that showed in Australia, when you look at alcohol care and bicultural alcohol care, there's just very little documented out there compared with what is documented in North America as well as in Aotearoa. So Gemma analysed interviews with Aboriginal staff in 11 community-controlled health services to come up with this model. And the model has been used in other healthcare settings now, including in oncology care in far western New South Wales. And it's also been used by one of my other PhD students who's a pharmacist delivering diabetes screening and care in an urban hospital. So Gemma's model has 3 levels, and this is the first level. It shows how First Nations Australian health professionals work around alcohol and community-controlled health services. And she really showed that relationships are at the heart of the care and the unique way that Aboriginal health professionals form the relationships. So you can see here at the bottom of the boomerang how far apart the health professional is, or you can apply this to a research sense, that might be the researcher, from the client or maybe the study participant. But with yarning and humour and giving something of ourselves, so sharing lived experiences, we can build a partnership of trust. So the thought that all of this work underneath the boomerang happens before you actually start the actual work of planting seeds and talking about alcohol and other drug use. The second level of Gemmers went on to show how First Nations Australian culture and Western culture are used together in alcohol care. So you can see here on the right-hand side, there are some beads that don't cross over to the First Nations side because the Western culture is the outer bead. So you've got things like relapse prevention medicines that I mentioned before, home detox that's medically assisted, and narrative therapy. And then you've got all of these other things as well. These are obviously just ideas talked about by the Aboriginal staff from those 11 services Gemma analysed the interviews data of. Finally, Gemma shows how the service structure can help, or sometimes it can also hinder staff ability to deliver effective bicultural care. So she's talking here about things that some are cultural things, like, you know, partnerships and the culture of how people work together, clinicians and other staff, but also the partnerships between staff and management, how many First Nations staff are employed, and flexibility around appointments and that kind of thing. These were some of the issues that kind of came up. Okay, I'm going to try and wrap up now. So I've talked you through a range of tools that we've co-created with Aboriginal and Torres Strait Islander colleagues in the last 2 decades. I think a really key part of these is that they were led by the priorities of the Aboriginal alcohol and other drug workforce and communities from around Australia. And now we're doing this work based at CAPA, or the Centre for Alcohol Policy Research, but really have a twin focus, not just on the research, but also on the workforce development as well, and giving back to that workforce. In terms of where to from here, in terms of some of the resources that you've seen and ones to come, in terms of the Grog app, it's a flexible and customizable tool to monitor drinking. As I mentioned, some services are using it for health promotion, and other services are using it for data capture. So the South Australian Health and Medical Research Institute is using it to collect data, not only about Grog, but also about Yandi. We've added 17 questions because they're doing a study with Aboriginal women who are pregnant and attending hospital. We are, at the moment, we're trying to make the Grog app talk to primary care software to make it easier for clients as well as their clinicians to screen for drinking and to deliver care. We're in the latter stages of development as part of an ideas grant, extending the Grog app to measure tobacco and illicit drugs. And if you're keen, just ping me later. We've got some really exciting developments here, I think, which really extend the brief intervention that I showed you before. So combining FLAGS, the WHO model, with Pat Dudgeon's social and emotional wellbeing model. So it's really exciting to have more points of connection to help individuals reflect on their drinking or the drinking of someone that they care about. And lastly, some of you may know we created a handbook in 2012 because at that time there was no quick reference clinical handbook for the Aboriginal alcohol and drug workforce. Other texts were out of date, or they were really pitched at medical or nursing specialty knowledge. So we're updating the handbook to reflect changes in the field in the last 12 years. So this includes things like the new drinking guidelines, way more information about methamphetamine responses, trauma-informed care, and also treatments for opioid dependence like Buvidal. So 5 out of 7 of the editorial team are Aboriginal alcohol and other drug workers themselves, some clinicians, some health service delivery or managers. So keep an eye out for that one as well. I'm sorry I went over. I think I should leave it there, but please ping me if you want to talk about any more of this story.
Thank you so much, Kylie. Thank you to everyone for listening. There's the QR code there for our survey. Now, Kylie, I've got a few questions for you. A number of them were around the Grog app. And, what kind of phone do you need? How do you access it? And is it available for services to use?
The Grog, thanks, Beck. The Grog app we developed only for iPad at this stage. The reason for that is because we started it in 2015, and the tablet technology has just really gone in leaps and bounds since then. So it is available as a private download on the App Store at the moment. The reason for a private download is that the CIs and I made an agreement that we were worried about basically the alcohol industry using the Grog app. It's quite a powerful tool. So just ping me, or I can, maybe Beck, you can give out my email address and I can send out a link. There's one link works once, basically. What we're doing with the drug app is that, which will become the new Grog app at the next year. The drug app will feature alcohol, but it's also going to have tobacco, cannabis, methamphetamine, heroin, opioid-based painkillers, and benzos. It will be available as a progressive web app as opposed to iOS. So what that means is that you can see it on your laptop. You can be able to see it on an Android. We still won't be able to see it on a phone yet. We're going to do that with the primary care grant. So when we get to the primary care grant, which we're just starting now, the primary care specialists have asked for it to be available on a phone. I hope that answers the question.
Thank you. Yes, I'm sure it does. Thank you so much. In the justice system, the judge often sets conditions for people who are on community-based orders around abstinence from drugs and alcohol. If a random test shows a person is using, that may result in a breach, which means the matter goes back to court. If a person hasn't freely chosen to address their use of substances, are these conditions unlikely to be helpful, and may they even cause harm because of their lack of success in staying abstinent?
Which conditions are you talking about?
So I think the question is around that some community-based orders might have abstinence conditions where a person must abstain from drugs and or alcohol. And do you think conditions like that are unhelpful or may even be harmful?
It's really tricky. I mean, I have lots of colleagues. I don't know if anyone else on the panel has sort of experience in more of the dependent space or the mandatory alcohol treatment space. I certainly have written a paper on it with some New South Wales health colleagues. It's a really tricky space to be in, isn't it? Because people need to be able to identify with their risky drinking in this case in order to make changes. So yeah, it's hard for me to kind of comment on the orders, because I think the orders sometimes are put by the magistrate because the person might be at risk to themselves or they have tried a number of different options already. But I'm not really a specialist on kind of court-based programs either.
No problem. Thanks, Kylie. Kylie, can you tell me more about how this work started and how research ideas were conceived?
It's funny, like I say that it's 2 decades because it really, it started in 2004 with me delivering a diversion and prevention program, which was funded in the NT when the NT government had to get rid of mandatory sentencing. I think many of you might remember that. So as a trade-off, the Commonwealth gave the NT, and they still have given them, which is wonderful, money to run prevention and diversion activities around alcohol and other drugs. So yeah, all of the ideas that I presented today stem back to that story. And the later work around the Grog app, that was really Scott Wilson and I talking in 2012 at the National Indigenous Drug and Alcohol Conference, and him saying, I see so many harms from drinking in the communities that his services in South Australia, but I don't see the funding for it. and us kind of looking at the discrepancy between the National Drug Strategy Household Survey and how many people are kind of captured as being current drinkers and risky drinkers, and how that didn't fit with what Scott was seeing on the ground either, which is where we've really sent us on this trail of now kind of looking at how to measure alcohol better, how to deliver brief intervention better in a digital sense. And I think that's really important because they're really tricky, sensitive topics to talk about, as you guys know full well. So I'm really trying to give more options for people to have these conversations and to have access to the information. So maybe when they do see their health professional or where they do see their drug and alcohol clinician even, that they're aware of some of the lingo and the words from the brief intervention. We use plain English, but then we we'll give the word that the doctor or the clinician might use as well. So really trying to use all opportunities to equip the individual, that the client or the person, to have the information that they need to kind of wrestle back control. Long-winded answer. Sorry, Beck.
No, not at all. Kylie, a number of people were interested in the videos that you showed. Just questions around where there was one in the beginning where there was a 1 minute clip and then one later on. Is there anywhere that people can access them?
I can maybe, when I give you the slides, I'll put the links on the slides as well, or I can write what to Google. They're all available for free, all of those videos. The communities have given permission for that. If you go onto the webpage that has, when I give you the link for Anaja, which is the problem drinking, the 1 minute clip, that also has other videos that the community decided to make around Yandi and around tobacco smoking. You can see a range of those videos there. It was really important for the community to want to share that with, just as an example, if it inspired another community. And I think the really key thing there is that kind of, again, the community development approach to how the films were created. So it really is, we started moving away from just doing instructional videos that I would create in Windows Movie Maker to actually creating stories, just a narrative, like a film that you would see at the Nova Cinema, which kind of is an amalgam of many, many people's stories in a given community. It's a really interesting, we actually wrote it up, the filmmaker wrote it up for us as part of Masters of Arts research, actually, that approach taken where you've got community partners in the making of a film that's about a really important issue for them, and how you traverse who gets to make what decisions, etc., in that filmmaking process, which is why it was really important for us to have Muriel as the executive producer, the kind of, we don't like how this is going, or yes, or no, you need to go to this person to ask to act that particular role, etc. So at every step of the way, the communities are happy with the decisions being made in the filmmaking process, which is really a health promotion process.
Thank you. Someone's just commented, very powerful stories from the community's view.
Thank you.
Kylie, can you just give us a bit more information about the handbook for Aboriginal alcohol and drug work and when it will be published, please?
Yeah, that one we originally launched at the National Indigenous Drug and Alcohol Conference back in 2012. The same conversation I had with Scott when we came up with the idea for the Grog project grant. So I think it's interesting that there still isn't that quick reference guide. The editors are, in addition to myself, there's Bradley Freeburn, who started and I believe is still running the AMS Redfern Alcohol and Other Drug program. Jimmy Perry and Scott Wilson, who both work for the Aboriginal Drug and Alcohol Council of South Australia. Julie Woods, who is an Aboriginal woman from Western Australia, who has worked for a long time in community-controlled primary care. And Lynette Bullen, who's a Wiradjuri woman who is worked as an Aboriginal AOD worker for 30 years. She at the moment works for IDAT, which is the Involuntary Drug and Alcohol Treatment Program run by New South Wales Health. and Professor Kate Conograve, who many of you will know, addiction medicine doctor, public health physician, and researcher. She's the seventh editor. We just got funded to do this work by New South Wales Health, and so very grateful to them. And we're, I think, probably looking at launching in 2026 APSAD, I think. So the Australasian Professional Society on Alcohol and Other Drugs. So 2026, 2027, we want to allow enough time to kind of get enough clinicians, as well as Aboriginal clinicians in particular, to review every section of the book and what we might change. So by all means, if you see the book and it's available for free online, I can put the link in the slides again. Then just let me know if you think anything's missing.
Thank you so much. Did any of these projects explore stigma and its impacts in the local community? Do you think storytelling helps address stigmas that may be present?
We didn't look at it as a primary variable, but the whole reason why we've developed the resources is because of the stigma and also the fear, as well as, actual racism that Aboriginal and Torres Strait Islander people face when they're going through their everyday lives, or certainly attending services as well. So I think trying to come up with a list of resources that are designed with Aboriginal and Torres Strait Islander people that they can feel comfortable to look at, that they don't feel judged by. Therefore, then they're getting the messages that we want them to get as well, have been really, really important. So totally, I think that's one of a primary reason is trying to increase access of Aboriginal and Torres Strait Islander people to these sorts of evidence-based messages.
Thank you so much. Can you talk about if the resources and tools can be used by non-First Nations workers with other people? Can you talk about if they could be used in the community-managed mental health sector with Aboriginal and Torres Strait Islander people too, where people might have both alcohol use and mental health challenges?
I think the first one, I remember the first one. Just remind me, Becky, if I don't know, because I think there are three separate bits in there. The first one, in terms of non-Aboriginal and Torres Strait Islander clinicians, we have lots of non-Aboriginal and Torres Strait Islander clinicians who already use the resources, particularly the alcohol awareness kit, and they refer people to the films. Obviously, they don't often have, a device to show the client, but they use the films, the brief yarns on alcohol films, as a way to upskill and to kind of look at other ways, other tips that they can use to get people thinking about their drinking. One of the best comments I received from a clinical nurse consultant who works on the drug and alcohol ward in Sydney, she said to me that as a non-Aboriginal woman, she obviously really appreciates being able to use the resources such as the alcohol awareness kit with Aboriginal and Torres Strait Islander peoples who come onto the ward, but she finds that they're so plain English. She used it with a Vietnamese man and with a Chinese woman and people from a range of cultural backgrounds, because at the end of the day they're kind of they're plain English, and they kind of really break down the concept of how to talk about a really tricky topic with people. And I think because for people that are culturally and linguistically diverse, because it's got the pictures there, even though you might have a different skin colour, or you might not identify as being from the community of people who are reflected in the pictures, you can see what the pictures are to make out the intention of the words as well. So I think that was a really interesting feedback for me to get. We are looking though at we're looking at the moment of the suitability of the Grog app for culturally linguistically diverse peoples and how we can change the Grog app for that benefit. Like, what was the second bit? The second
could it be used in community managed mental health in the community managed mental health sector with Aboriginal and Torres Strait Islander people, where
and with mental
might
health
have
as well.
both AOD use and mental health challenges?
Yeah, I think the thing, you guys are experts in this. I think the thing for me is that alcohol and other drug use comes up everywhere in the health sector. So we certainly have had people use the handbook, for instance, um, because they're just really after a quick reference guide with tips for how they could have these tricky conversations with their Aboriginal clients coming through the door. So I think that they could certainly be used across if the client has a presenting troubles with alcohol and other drug use. I think you could certainly use the resources or the concept of the resources. In terms of mental health, we're actually looking at funds to kind of combine the Grog app with the mental health screening tool. And that's one that two of our Aboriginal research support team are so keen on, because finally they understand why we had to start with the Grog app and get that right and then move to other drugs. But finally, we're kind of we're not kind of slicing and dicing the person and saying, I'm only going to look at your alcohol, I'm only going to look at your drugs. We're actually trying to get funding to kind of look at AOD and mental health at the same time. And I think that's a really important space to go. We tried to do it a bit with the drug app, particularly with the methamphetamine and the Yandi questions that we added in. But as soon as we started, I just realised it's just gigantic in terms of trying to get those questions working, and how do you feed it back in a way that's going to really be safe for people listening to the feedback as well, and taking into account everyone's strengths as well as the challenges that they're facing in life. So yeah, that's kind of a watch this space. It's coming.
Sounds like lots of good things are coming. Thank you so much, Kylie, for your time today. Is there anything that you want to leave the audience with?
No, I think that's enough. Yeah, thank you.
Thank you so much, and thank you to everyone. We appreciate your feedback by the QR code, and the webinar will be available on our website in the coming weeks. And Kylie will generously provide us with a PDF copy of her presentation. Lots of people said thank you and that it was super helpful. Thanks, Kylie.
Thank you so much.
Bye,
Bye.
everyone.